Well, thank you very much for the invitation. It's an honor to be here. And you'll have to bear with me because when you have to present 4 or 5 different lectures at one time, there's only certain of them that you can make fun or interesting. And this is one that I thought we could make it a little more interesting. So if somebody could just put my slides there. This is an interesting topic, and it evolved a lot. But certainly teams were originally designed to pull a sleigh, and that's what the original definition of team. But the teamwork issue really was getting a group together with a unified purpose. So subserving the smaller to the larger picture, and that's really what this is all about. I'll take cardiac surgery for the coronary, which is really what the discussion will focus on. I'll come back to this, but certainly it's the best and the worst that's happened, and clearly it helped many patients. It brought prestige. It floated hospitals, and it rewarded surgeons. But on the other side, it had a number of negative effects. And let's see if I can. Do I have a pointer here that? No, to put onto the screen. Could you go to the bottom of that screen and just hit the play? So cardiac. I don't have the ability to control the computer. So this is what cardiac surgery looked like for years. And we as cardiac surgeons were it was just wonderful. Life was so good. We couldn't, it was just ecstasy. Okay, you can go to the next slide, please. Yeah, and we were all happy. But the worst of it was that we became a commodity. And we then got subjugated and things changed. And clearly, the cardiologists were closer than they appeared in the mirror. And when Grunzig did the catheter, all of a sudden, we said all sorts of things. And Dave Taggart will know this. It won't work. It's no good. It's not going to happen. And yet, PCI took off, and it just exploded. And we ended up standing outside the cath lab. This is Mike Mack, who's a dear friend of mine, and helped me with some of these slides. And this is what we did. And could you play this? Hit this one that says play at the bottom. And here we are now in the 2000s. I wish you could hear the music, but we're just plodding along, waiting, and we just don't want to give up. So what happened then, obviously, was this tug of war between the surgeons and the cardiologists. And we sat in the vulnerable position that said, come on, Moses, stop this. And obviously, we became worried. We were going to become the dinosaurs. And to a certain extent, that hasn't really changed dramatically. And at this meeting a couple years ago, obviously, it was the rise of interventions and clearly intervention in cardiologists, but the interventionalists were leading here and the surgeons were behind. Well, what happened? Well, there was a couple things that happened. One was the rematch trial that showed that ventricular assist devices were better than medical therapy. And secondly, the Syntex trial, which David has so eloquently shown, and clearly the partner trial, and this is really a catalyst for teamwork. This has changed the playing field. And clearly, with coronary interventions, it became that in left main and 3-vessel disease, impaired ventricular function, we needed to discuss these cases. It remained the standard. And so for that reason, we should be at the table. And the guidelines clearly even say here, the appropriate revascularization strategy in patients with multivessel disease should be discussed by the heart team. So it's gotten incorporated into the language. It's now our little byword, a guideline. The question is, what does that mean? And it means different things in different places. So clearly, we have the recommendations and what we're supposed to do, and surgery is at that table. Now, we have a long history of working with cardiologists. And we can go back to Tausig and Helen and when we developed the Blaylock-Tausig shunt. And when we then look at the multidisciplinary teams, some are easier than others. So for instance, in heart failure, we at the University of Washington, every Thursday morning for 2 hours, every patient gets discussed. And it's a multidisciplinary team. And I would say that probably more important than the cardiologist and the surgeon, not just for coronary disease, but it's everybody else that's involved. And it's a decision making that has to do with efficiency, guidelines, the management of patients. What is the whole course of that patient expected to be, and why? Why? Start with why. Why are we doing these decisions? There's a great book out there called Start With Why. It's one to read. It only takes an hour, but it's the key here and makes it important. And this is Mike Mack as a head of STS a couple of years ago, and the team, they said, well, this is the Venn diagram. They wrote a paper, actually, about the team concept. Well, the collaboration levels also have an impact, and this is a double-edged sword, because it has an impact nationally in how we organize things. And we're closer to organizing as a multidisciplinary team in cardiovascular care than we have before. Interestingly, there's some unexpected consequences, because what this ultimately does is that it has the potential to put surgeon against surgeon now as we make the new alliances between surgeon and cardiologist, particularly as we centralize care, because the people in the periphery also can get marginalized. But clearly, all sorts of different levels. And once again, in my world, this departmental and practice model is a big issue, because cardiovascular services is the boat which floats all of the other departments in medicine and surgery particularly. In my department, our budget is $23 million we bring in the Department of Surgery, and there's 65 faculty members, and almost 30% of that revenue comes through cardiothoracic surgery based on 11 faculty members. So they don't want surgery to go away. And the same statistics, maybe even worse in the Department of Medicine, go on. So we have to be careful. But clearly, based on this, there's daily examples now how this is increasingly becoming part of our world. And we have to adopt it. And we can win by it, because the boat gets elevated. But as I said, the politics are local. And we tend to live in these silos. And until we break out of our silos, our comfort zone, we live for all of these years. If we don't embrace the change and understand the mechanism of herding the elephant and showing the path and going through the landmarks of what changes, we're going to continue to struggle with this. But we have culture, workflow, logistics, financial. We haven't really proved that we changed things yet, so there's no proof of evidence yet. And maybe in a lot of patients it's not necessary. So what happens in the United States since we've had this teamwork with coronary surgery? So actually what happens in actual practice, and this was a study that was done in the state of New York, 19 hospitals, patients undergoing coronary angiography. They then looked at who went to PCI, CABG, medical therapy, or nothing, and they compared it to the American Heart Association guidelines. So there were 16,000 patients. Interventional cardiologists were still kind of the gatekeeper. They were still the gatekeeper here. They didn't really have the multidisciplinary team a priori, and that becomes critical, because then when you look at the data, if you take it the guidelines, so these were the guideline indications when you retrospectively looked at it, CABG would have been 13%, but of that group, only 50% were recommended for CABG. On the other hand, when you looked at those that met the guidelines for PCI, because the cardiologists, 93% of them got recommended a PCI. And when it was either one, you still had the propensity towards PCI. So we still have a way to go. It's more frequently recommended in the United States yet, and so we still haven't adopted. I mean, this isn't anything you'd not expect, but it's just showing this transition that we're going through. In my state of Washington, we have a COPE, Clinical Outcomes Assessment Program, where everybody participates in it, and we looked at the guidelines similar way, put them into different guidelines where the appropriate. And for an acute MI, the cardiologists followed the recommendations classically. They followed it within it. And in that situation, a lot of the guidelines favor coronary interventions. And it's only in the non-acute or the chronic whereby, obviously, there were still a number of inappropriate recommendations. So therefore, we still have a way to go. And clearly, this is your paper from England where you introduced the heart team concept. And I won't throw the data, but obviously it makes some benefit. So teamwork. Could you play this one? Please don't be offended. It's just meant to be funny. This is teamwork. Can you put the sound on by any chance?
You got a light, mate?
Yeah, I have. Hold this a minute.
Excuse me, mate. Can you hold up for a minute?
Yeah, sure. Sorry, I've finished. So I'll take care of that.
I've finished.
Me too.
So we have a way to go. But I think that politically it's evolving. We have to be at the table. There's huge contributions that we can make as surgeons. It increases our awareness of our environment. It makes us work at all of the other things that we have to do better in terms of communication. We're just not at the end of the feed line. We don't want to be there. We want at the beginning of the decision making. And the earlier we get into it, the more that we see it, the better off we're going to be. And I think that you can organize it in any way that you want to. At the University of Washington, we have a CAP conference every Wednesday for an hour. It reviews mostly coronaries. We don't have the patient care concept up front. Every Monday, I have the adult congenital clinic because if there's a group that you need lots of opinions, it's these complex congenitals, so a fourth and fifth time redos that really, so we've had that, and that makes a huge difference because we're at the table and we talk about it, we go through the risk of surgery. It makes me be aware of what I can and what I can't do. Every Tuesday, we have our partners trial, 2 hours, everybody's in the room, and we talk about all of the aortic valve options, how we're going to approach it, and we go through every single step in preparation of it. I can't stand it. I can't stand the hybrid suite where there's 25 people in there. We're making decisions by committee when to tilt it. Now's the time to blow up. I don't like that. As an open surgeon, I can't stand that. But the decision making up to it is essential. And I think with coronaries, we'll see the concept, although I think that's going to be a much slower adoption because we have so much tradition of the way we've handled them going through cardiology. But I think it's important to evolve. And in the big picture, I think that for the efficiency of your hospital, for cost cutting and everything else, defining the pathway, bringing all of the people together. So our social service people come in, our physical therapists, our anesthesiologists, they all participate in all of these things. They're not as active as some of the professional people, but they understand what the expectations are, so they define the entire process, and ultimately what benefits is the patient. So clearly, if we keep in mind the patient makes the difference, the efficiency, the expectations, and that's why the teams are so critical at this juncture in time.